My name is Keith Carson, Director of Partnerships with Therapy Specialists. I've been fortunate enough to be joined by Kelly Cooney, our VP of Compliance and Training. We were just going to have a conversation about the new proposed rule and specifically the new SNF payment system that is being proposed. As you may know, back in 2017, they had introduced RCS-1. There were a number of comments and feedback that was given to CMS as it related to RCS-1. So adjustments have been made, and recently they have come out with a new proposed payment model. This is called the patient-driven payment model. I got to say that slowly. The patient-driven payment model. And so, Kelly, I wanted to just ask you initially, what is CMS really trying to accomplish at a high level with regards to this change in the payment model?
Absolutely. I think that the biggest message that I've heard from CMS is that they're really trying throughout the continuum of care to change payment from volume to value. A lot of healthcare set up right now that more is better. Certainly research shows that that's not always the case. And so they're really working to change how they pay for services to reflect more the needs of the patient versus the volume of care that's being provided. So this new model is set up to be patient-centered. I mean, the RCS-1 was called Resident Classification,
System, yeah.
and the new one, PDPM, is patient-driven payment model, right? So they're really trying to...
Even with the language, they're trying to say,
to
hey,
really
we're
drive
focused
this
in
one.
on, yeah.
Absolutely.
Right.
And then I think a third thing that they're really trying to do is eventually get to something that's a little more site neutral in terms of payment. That, you have this issue and, we could send you to these 3 different options. Where should we send you? And should we pay more for this one or not? So they've moved some things along that will give them some more data about how effective each setting is. So the section GG items have been added. The care tool items have been added now to skilled nursing, the inpatient rehab, patient assessment instrument, the IRF-PI for inpatient rehab, and the OASIS for home health. So they can compare apples to apples.
Yeah.
If I send my total need patient to all 3 of these settings, where do they do best?
So why is the section GG piece as well as the care tools so important in this new patient-driven payment model?
That CMS spent a while looking for a tool that could cross the continuum, and they settled upon the care tool, and then they've tweaked it a bit to be section GG. They've changed the item set a bit.
Got it. Okay.
So it's based on the care tool, but they've tweaked it up a little bit in terms of the scoring to fit into the MDS, to fit into the IRF-PI, and to fit into the OASIS. So the care tool items are where this all originated, but it's evolved over time.
And the intention of those is to help you or help them to be able to track outcomes a little bit easier across different types of care settings.
Correct.
Meaning the SNF, meaning home,
Right.
hospital, well, specifically post-acute.
Post-acute
right?
currently.
Yeah.
And also to compare provider to provider. So those items are already driving the quality measures on the 5-star website for each building.
Yeah.
So they're being used in a lot of different ways.
Yeah. So let's get back to the patient-driven payment model. So I think one of the questions that I've been asked, and it's a difficult one for me to answer, so is this good or bad for us as providers?
Sure. I think that always doing the right thing for the patient is a good thing.
Yeah.
And this model really drives that, right? It drives decision-making based on patient need. And it takes that need to meet any sort of minutes or do anything that's not patient-centered out of the picture, which is great. Some of the feedback that was given to CMS about the RCS-1 model was that there was potential for therapy service to be under-delivered. And so CMS listened. And now there is the new proposal includes inclusion of therapy minutes provided on the discharge MDS. And so there will at least be some tracking of
Calculation and tracking of it.
and CMS has been clear that they don't expect to see huge practice changes, even though the payment model changes.
Yeah, which could be difficult for providers.
Right, exactly. Exactly. I think that some providers that have been, and they said this in the rule, that have been providing a high level of therapy, doing primarily ultra high therapy with most of their patients and with lengths of stay that are above the average, we'll probably see some changes to their reimbursement.
Sure.
For the provider that has a little bit more of a balanced approach within average length of stay, may see their reimbursement stay pretty similar.
Yeah.
So, but those are all still, things that are in the works in terms of the analysis of what this looks like.
Yeah, totally.
It's a very, very complicated system. It's very complicated. So it's going to take a while for, I think, CMS to run the numbers and for, provider groups to run the numbers to determine what the impact really looks like.
Can you think of just a few things that providers need to be thinking about even now to begin to prepare for this new payment system?
Right.
What are the ways in which they're going to have to adjust their approach with their patients?
Yeah, there's a few things that I recommend right away. Making sure that your MDS nurse is solid, that your MDS nurse is knowledgeable about coding, that your MDS nurse is really coding accurately, especially Section GG and the items that are going to drive this payment model, as well as are driving your quality measures now. Making sure that you're prepared and someone on your team is really moving towards becoming, if they're not already, an expert on ICD-10 coding. ICD-10 coding plays a huge role in this new reimbursement system. So having someone on your team that is maybe even a certified biller and coder, and working with your hospital to make sure that you're getting good information from them.
Sure.
Like now's the time to, if you're not, to figure out how to get it, showing your value.
Yeah.
Being able to, keeping an eye on those quality measures, keeping an eye on those outcomes, and making sure they don't change when this payment model changes.
Sure.
Because those are the kinds of things that are going to cause you problems.
Yeah. Well, thanks for your insights, Kelly. I really, really appreciate it. If you would like more information on the patient-driven payment model, we will continue to keep you updated on our blog. You can find that at therapyspecialist.net. But I hope you find this useful and valuable in your role at the skilled nursing facility. Thanks.